Okay, this is looking at Unit 9, Investigating Disease. So in this, we are going to look at two different diseases, a communicable and a non-communicable disease. And the format we are going to follow will be the same for both of them. So I am going to talk through generically about what would come under each one of these headings, and then I'll talk specifically about one disease so you get an idea of where we're going to go. So when we look at diseases, we have to actually identify what they are. So we have to say what a communicable and what a non-communicable disease is. And we've already covered that prior to coming to this part of the coursework. So now we are going to look at what a disease is in terms of the biological basis of a disease. Now by that I mean, what are the signs and symptoms of the disease? So we might call it another word, the pathogens, which is just meaning what does the disease look like. So in terms of biological basis, we need to know that a sign is something you can see and a symptom is something that you feel. So a very general one would be vomiting would be a sign because you can actually see it. And a symptom would be someone saying they felt nauseous or they felt sick because you can't actually feel it. You can't actually see that. In terms of causes or risk factors linked to our diseases, we can put them under 5 headings and we can look at how they would impact on our disease. So lifestyle. Linking with lifestyle, we could talk about whether someone's healthy in terms of their diet or their exercise. Do they smoke? Do they drink? Do they take drugs, prescription or recreational or illegal drugs? Age, we could look at, has any of the factors in terms of your disease, is it linked to age? Is it age related? Does it happen because someone's old or young, or is it just across the whole spectrum? Gender, if we're looking at gender, male and female, is it predominantly a female condition or is it predominantly a male, or again, is it sexless in terms of gender? Social class, can we link it to anything related to social class? Can we link it to people who have poor housing, therefore they might financially be having difficulty with their diet, their lifestyle, which would also link with environment. What is their housing like? Do they have noise pollution? Do they have air pollution? Is there have they access to healthcare services around them that might impact or increase their risk factor for this disease? Okay, prevention. If we look at how we can prevent or reduce the incidence of our diseases, first thing will be education. How can we educate people to hopefully reduce diseases? Can that be through schools? So can we have a schools programme? Can we have education in the community? Can we have education through GP surgeries? We can also link to media, which I've put down here. So can the media influence prevention and reduction in diseases? Or can they actually be a factor that can hinder prevention if we've got mass hysteria, as we had with the MMR vaccination a few years ago? We can link those with strategies. Do we have any strategies that are around that have been linked to education that can prevent and reduce diseases? Just screening programs that we have for things like breast cancer, we have them for cervical cancer, we have vaccination programs, inoculation that go right from birth right through to the 75 plus if we're looking at flu vaccinations. Can we link it to cost as well in terms of prevention and reduction? How much would it cost? Is it cheaper to try and prevent a disease through inoculation rather than having to treat someone? And don't forget that cost can also link to days off work. That can be a financial implication as well. Can we link that to access to healthcare services? If we think about one of our risk factors where we talked about the environment, has everybody got access to healthcare services? Are they able to access a doctor Or is that something that can also hinder as well as reduce? Well, how do the public perceive that they might actually have this disease, or that it's never going to happen to them, is probably the biggest phrase that you hear in terms of things like smoking. People will say, oh, but great Auntie Maud, she smoked 50 cigarettes a day and she lived till she was 105 and was never ill in her life. But that might be the exception. We have to think about, how can we get our message across that, it is a bit more than just that. Patient-doctor concordance. Okay, well, what we mean by that is patient and doctor in agreement. For your medical care to work, which links with patient compliance, you actually have to agree with what the doctor would like you to do. So if you are not going to agree with the care and maybe changing diet, changing your lifestyle, taking drugs, then you're not going to get better. The diseases actually could get worse. We can link that with antibiotic resistance. If you think about taking a course of resistance, one of the biggest issues is people actually completing the antibiotics. After about 2 or 3 days, people start to feel better, so therefore they stop taking the antibiotics, and then they find they get ill again because the disease, the condition, the illness, whatever we want to call it, gets worse. And that's because it has actually mutated against that antibiotic, because it's not had time to kill it completely, and therefore it's mutated, it's changed, and when we try and treat it with that antibiotic again, it's resistant to it. So we'd have to try another antibiotic, but also the patient who's got the illness is ill and possibly even iller still. So therefore we've got to find something else. So 10 years ago we might have been able to treat something with 2 antibiotics. These days we might take 8 or 10 antibiotics, and that's actually something we are concerned as a nation that it's going to be our biggest problem in 20 years' time, is antibiotic resistance, and the fact that most people are not going to be able to be treated with antibiotics because there isn't going to be something that will be able to treat them. That can link to funding availability. Have we got the funding to enable us to do research and prescribe all the new drugs that keep people alive, that prolong their life? Where's the funding coming from? Our NHS service isn't infinite in terms of our funding, so therefore are we going to be able to fund treatments? We have an ageing population, people are living longer, people are healthier, but also it means, in terms of our drugs and our treatment of our diseases, we have to think about what's best for everybody at the end of the day.